Hello, everyone. My name is Adil Sheikh. I'm a first-year cardiology fellow at Southern Illinois University in Springfield, Illinois. And today I have Dr. Marie Shafi de Kroning with me, who's going to be talking about the GIPS-IV study. Marie.
Thank you for the introduction. Let me tell a little bit more about the study. The aim of our study was to reduce damage after heart attack, since there is currently an unmet need for therapies that protect against ischemia reperfusion injury. And to do so, we did it with the investigational compound sodium thiosulfate. And sodium thiosulfate is a known HTS donor, a hydrogen sulfide donor. It's a hydrogen sulfide donor. And for hydrogen donating compounds, there is a lot of preclinical evidence that indicates that it reduces damage after heart attack. And it was not only in small animal models or cellular models, but those effects could also be substantiated in larger animal models, including swine models. In dogs, it was also demonstrated, and that was why we designed the GIPS-IV trial. And in the GIPS-IV trial, we randomized 380 patients who presented with the first STEMI and had ongoing symptoms and/or complaints at presentation, in order to ensure that we aimed for patients with still closed vessel where reperfusion still needed to be established. And those patients, we randomized them to either receive sodium thiosulfate intravenously or matching placebo. And the first dose was directly after arrival at the cath lab, and the second dose was administered 6 hours later. So that was basically what we did during hospitalization. And at 4 months follow-up, we determined the primary outcome, infarct size, measured by delayed enhancement, late gadolinium enhancement, and several secondary other outcomes. And I think what really important of this study was that it is the first translational attempt to translate the wealth of preclinical evidence into a human study. So that's basically it for the design.
Thanks for the nice summary. So basically, we looked at reduction in infarct size after administration of sodium thiosulfate, which is a hydrogen sulfide donor, and we did that by getting MRI images for infarct size assessment at 2 months.
4 months.
4 months, sorry. Okay. Can you tell us a little bit more about what your results were?
Yes, at 4 months we determined the primary outcome, which was infarct size, and we unfortunately did not observe a reduction in infarct size. Also, our secondary outcomes, left ventricular ejection fraction at 4 months, measured with the same CMR of magnetic resonance imaging scan, and NT-proBNP levels at 4 months, as well as enzymatic infarct size during the index hospitalization, were comparable between the treatment arms, so it was not reduced. I think what's also important to mention was that the mean infarct size in both groups in the sodium thiosulfate group was 8%, and this was 8.9% in the placebo group. So I think in average, our infarct sizes were small that we observed. Regarding safety, the number of major adverse cardiovascular events during 4 months follow-up was low and comparable between the treatment arms. And also the number of serious adverse events was similar. So we did not observe any safety signals, but we did observe that the known side effect of sodium thiosulfate, which is nausea and vomiting, occurred more frequent in the sodium thiosulfate group. This was also transient and manageable with the preventive use of antiemetics, but it was still an adverse effect what we observed. So that were our results and observations.
Thank you so much. So it sounds like the trial was negative for the primary endpoint of reduction in infarct size, but it also appears that the left ventricular ejection fraction was also not affected. Was the EF right after the STEMI also normal in these patients?
We did not standardly assess left ventricular ejection fraction during the next hospitalization. I think for many patients that was the case, but patients were also referred to regional other hospitalization of hospitals for their recovery. So I don't have any data on that. Of course, a substantial amount of patients had a reduction in infarct size, but what we observed and measured in all patients with a cardiac magnetic resonance imaging was that the infarct size was preserved, and on average 55 to 56%.
The other question I was wondering was that how much was the utilization of other therapies like statins and aspirin and P2Y12 inhibitors, especially if people can't get them oral, were they given IV, and was that a reason that we didn't find positive results?
In the Netherlands, before patients arrive at the hospital, they already had aspirin, ticagrelor, P2Y12 inhibitor, and heparin intravenously. So, a part of our patients already had reperfusion due to the antiplatelets that they received in the ambulance. So that might also be an additional explanations for the small infarct sizes that we observed. And I think on average at discharge, but also at 6 weeks and 4 months, when we assessed the concomitant medications, nearly all patients were on double antiplatelet therapy and were also well titrated on beta blockers, ACE inhibitors, and statins. So I think those rates were above 80%, and for beta blockers 90%. Yeah, something around that.
So it sounds like you had a cohort who was already on good medications to begin with, and even in the control arm, the infarct size wasn't great. I think it was 8% and decreased to 7.7% with the sodium thiosulfate. Do you think that if the same trial was replicated in a different setting, where patients are more sicker at baseline and at presentation, we might see different results?
Yeah, we cannot exclude that in a patient at higher risk there could be a positive effect in the reduction of infarct size of sodium thiosulfate. And I think in Groningen we did many studies for the preservation of infarct size, which targeted ER injury, and compared with the previous GIPS-III trial, which investigated metformin to preserve cardiac function, we applied an extra inclusion criterion that patients had to have symptoms and/or ST deviation, and thereby we aimed to exclude patients with a small infarction, and we aimed also patients to include patients. We also aimed to include patients with still closed vessel. But in practice, we did not. We still saw a lot of small infarctions, and I think the patients were treated after 2 to 2.5 hours, so really fast, really effective. So that definitely affected our results. Yeah, I think so.
Well, thank you so much. One last question is, what are your future plans for the study? Are you going to look at expanding it, or maybe expanding it to other indications like heart failure and so on and so forth?
As mentioned, we cannot exclude that there is any effect in patients at higher risk. So we used sodium thiosulfate as a HTS donor, as a hydrogen sulfide donor, but we also cannot exclude that other HTS donating compounds could demonstrate a benefit. And sodium thiosulfate is one that is already clinically approved. This was very logical and promising to investigate, but I think in the future maybe other HTS donating compounds or in different dose regimens could be investigated. And what I also think is that HTS has a lot of pleiotropic effect. So it also has effects on angiogenesis and fibrosis. So I think maybe combined strategies of sodium thiosulfate, of a comparable compound, which has a instant effect during the reperfusion, combined with maybe a longer, slow-releasing hydrogen sulfide donor for heart failure. I think we should think more in that way for cardioprotection.
Well, thank you so much. For more videos like this, please go to our YouTube channel, Fits on the Go, and follow us on Twitter.